Yesterday, we discussed another example of obstructive airway disease, that is asthma. And the COPD is the other obstructive airway disease that I'm going to tell you about. The COPD word stands for chronic obstructive pulmonary disease. And this slide I showed you yesterday also, the COPD. And the pathologists have told you, and you have learned from them, that there are two extremes, two ends. That is, one is chronic bronchitis, and the other one is emphysema. That is pathologically. But clinically, we do not make a distinction, or we do not distinguish between these two. We make the diagnosis of COPD. But pathologically, there will be two different entities, emphysema and chronic bronchitis. The same patient, sometimes, not sometimes, most of the time, both these entities exist. So one patient might have more emphysematous changes, and another patient with COPD might have more chronic bronchitis changes. But clinically, we label all of these as COPD. And we talked about asthma, and also we mentioned that there may be a small minority or group of patients. We cannot really put a clear-cut label with either COPD or asthma, and there is some kind of overlap, and we call it asthma COPD overlap syndrome. Yes, any problem? Yeah. You raised your hand. Can you hear? If you can't hear, come on the chat box and let me know. What is COPD? This is also a disease characterized by airflow limitation, just like asthma. But unlike asthma, this airflow limitation is not fully reversible. That is one important difference from asthma. And this airflow limitation is usually both progressive. In asthma, if you remember, there was a huge variation within the day and also in between the days. Some days it's really bad, some days it's much better. But here, this variation is very minimal, and it is more progressive. And it is associated with an abnormal inflammatory response. So this is also chronic inflammatory disease, just like asthma. And that inflammatory response of the lung is due to exposure to various noxious particles or gases. The most important of this, or most significant one, is tobacco smoking. So the keywords here, the COPD, this is characterized by airflow limitation that is not fully reversible. And this airflow limitation is usually both progressive and is associated with an abnormal inflammatory response, which is usually to tobacco smoking. So tobacco smoking is the #1 cause or etiological agent in the causation of COPD. So there are some differences, clinical differences also from asthma. Asthma, as you know, onset is usually early in life, or they might give a history of childhood asthma or family history of asthma. Symptoms vary from day to day. Symptoms are mostly at night or early in the morning, where there's a diurnal variation, and this is the time that peak flow rate is reduced and the airflow limitation is more severe. And they are usually atopic subjects, therefore there are allergies, chronic rhinitis or eczema may or may not be present. But just because these things are not there, one cannot rule out a diagnosis of asthma. These are associated things, and airflow limitation is largely reversible. and it is reversible either spontaneously when they go into remissions or in response to medications like bronchodilators. Also, we can demonstrate this reversibility by doing spirometry before and after bronchodilator therapy. Whereas in COPD, its onset is more or less in midlife and symptoms are slowly progressive without much variation. And there's usually a long smoking history. This is not essential, but we are a little reluctant to diagnose COPD in those who do not smoke cigarettes, but other exposures like cooking fumes and other industrial exposure, environmental exposure are also important in the causation of COPD. This is exertional dyspnea, dyspnea during exertion, and the airflow limitation is largely irreversible. There's some kind of disturbance in the, I think, the internet connection. If you can't hear, just let me know in the chat box. I'm monitoring the chat box. So there's an overlap, COPD and asthma. Some of these patients have features of COPD and some of the features of asthma. Also, I mentioned that patients with COPD will have both changes of chronic bronchitis, which are learned in pathology, and changes of emphysema. This slide I took from your path lecture. There are features of emphysema. There's increased airway resistance. Is common to both emphysema and chronic bronchitis. Being a smoker is also common to this emphysema and chronic bronchitis. Symptom-wise, patients who have more of chronic bronchitis, they have more cough and mucoid sputum. Those who have predominantly emphysema changes, there's not much of cough or mucoid sputum, then their main symptom is progressive dyspnea. Another important difference between these two is that the pathology is at acina level in emphysema, and because of that, there's a loss of alveolar capillary units, and there's damage to diffusion across the alveolar capillary membrane. And you know that there are ways of measuring this diffusion using carbon monoxide diffusion factor as a measurement. Whereas in chronic bronchitis, pathology is more at bronchial level, and these alveolar capillary units are not damaged. They remain intact, and there's hardly any change to diffusion across the alveolar capillary membrane. So if you are speaking lung function wise, there is increased airway resistance here, plus diffusion, impairment of the diffusion. So there's bronchospasm or airflow resistance plus impairment of diffusion across the membrane. Whereas in chronic bronchitis, it is only the increased airway resistance without any problem at alveolar level, without any impairment of alveolar capillary diffusion. There are so many factors which the pathologists have discussed in their lecture. Host factors, including genetic factors and lung growth during the fetal time, and many environmental factors that one can influence. Out of that, the most important is tobacco smoke, but the environmental pollution, occupational dust are the other factors that can be influenced. In COPD, central airways, peripheral airways, the lung parenchyma, and vasculature are all involved to a varying degree. Again, in chronic bronchitis, is mostly central airways and peripheral airways. In emphysema, there is involvement of the parenchyma and vasculature. So, if the central airways are involved, there is mucus hypersecretion and ciliary dysfunction that leads to chronic cough and sputum production. Because of the ciliary dysfunction, these patients are more prone to get recurrent infections, chest infections. When the peripheral airways are involved, because of the inflammation, there's airway remodeling, and there's a healing with fibrosis and scar tissue formation. Because of the scar tissue formation, the airflow limitation is now fixed. Unlike in asthma, where it remains reversible, because this main problem is smooth muscle contraction and mucous secretions and mucosal edema. Here there's fibrosis because of the airway remodeling and fixed airway limitation. When the airways are blocked or narrowed, there's air trapping inside the lung, and there's a dynamic hyperinflation. The lung parenchyma is involved in emphysema. There's a loss of elastic recoil. The elastic recoil is important to keep the airways open, prevent them from collapsing during expiration. So when there's a loss of elastic recoil, it adds into airway limitation or narrowing of the airways. And there's impaired gas exchange because of the damage to alveolar capillary membrane. When the lung vasculature is involved, there's pulmonary hypertension. So what is the ultimate result of that or consequence of this? Because of the fixed airflow limitation, there's a FEV1 FVC ratio is reduced. When there is a dynamic hyperinflation of the lungs, there's air trapping, residual volume is increased, total lung capacity is increased. When there is narrowing of the airways, produces rhonchi or wheezes, and the chest looks barrel-shaped chest, which you can detect clinically. So there are signs of hyperinflation of the lungs, and in extreme hyperinflation of the lungs, the chest looks like a barrel and it's called barrel-shaped chest. Now there is hypoxemia, both contributed because of the narrowing of the airways as well as the impaired gas exchange, and which you can measure by using a carbon monoxide diffusion capacity. So the lung functions as a low diffusion capacity. Hypoxia also causes pulmonary vasospasm, and it contributes to pulmonary hypertension. So this is whole, the consequences are, there are several consequences because of this involvement of these four elements in the lungs: central airways, peripheral airways, parenchyma, and vasculature. This is a chest X-ray showing an example of hyperinflated lung. To compare with a normal lung, this is a normal lung. Lung fields look blacker than the rest because there's air inside there called radio translucent. It's an emphysematous lung because there's a lot of air in the lungs. They look darker than usual. Increase radio translucency. Diaphragms, which are usually nice and dome-shaped, are now pushed down because of air trapping, and the diaphragms are flat and low, lower than in the normal position. Again, because the lungs are hyperinflated and the diaphragms are pushed down, this mediastinal shadow looks thin and narrow and long. So there are radiologically on the chest X-ray, there are signs of hyperinflation, that is increased translucency of the lung fields. Its lungs look blacker or darker, and the lung markings are less visible now when compared to this normal lung. Mediastinum looks long and thin. The diaphragms look flattened and lower than in the normal position. So these are signs of hyperinflation on the chest X-ray. If you look at spirometry, this in the normal person, you ask the patient to take a deep breath in and breathe out as hard as possible and as quickly as possible. Amount of air that is expelled in the first second is called FEV1, and amount of air completely expelled is FVC. So we look at the FEV1 over FVC ratio. In a normal person, you can calculate that. And in a patient with COPD, FEV1 over FVC ratio is 70% or more. In this patient, it is about 60%. So that is an indication of obstructive airway disease. So what is the difference from asthma? In asthma, this FEV1 will improve after bronchodilator, and that shows that there is a reversibility. Whereas here in COPD, there's a reversibility is lost. Why? Because the airway narrowing is more permanent, or is a fixed airflow, a limitation because of the remodeling and fibrosis that is happening as a result of inflammation. So inflammation that you see in COPD is different to the inflammation you see in asthma. There's hypoxia, and hypoxia is one of the potent stimulants for pulmonary vasoconstriction. That leads to pulmonary hypertension over a period of long time. When there's pulmonary hypertension, the right ventricle undergoes hypertrophy, just like how the left ventricle undergoes hypertrophy when there is systemic hypertension. After a while, if it remains like this, right ventricle fails. When the right ventricle fails, you get signs and symptoms of right ventricular failure. Before that happens, right ventricular hypertrophy can be detected on the ECG. There are some ECG features: the right axis deviation, positive R wave in V1, and the right bundle branch block. And if you do echocardiogram, again you can detect right ventricular hypertrophy. When there's a right ventricular failure, it produces peripheral edema or dependent edema. Jugular venous pressure is high, it's a raised jugular venous pressure, and one gets tender hepatomegaly. So the right ventricular hypertrophy can be recognized on the ECG with these features. And when there's failure of the right ventricular failure, you get edema, high JVP, and tender hepatomegaly. This is a normal ECG. This is the normal P wave. And in V1, you can see QRS wave is predominantly negative. If you look at the patient with right ventricular hypertrophy, one can see, particularly in L1, that there is a tall, very prominent P wave. This is called P pulmonale. So it is the second lead 2, that is best to look at the P wave. It's a tall and tented, it's like a bit of a tent-like, tall and tented P wave called P pulmonale. And Unlike in the previous ECG, here you will see in your V1 lead, the main wave is positive. The normal ECG is a negative wave. This shows that there is a right ventricular hypertrophy. And in this lead, you can see that there is a M-shaped complex here. This is due to right bundle branch block. It's a conduction defect of the right bundle. So these are the three features, electrocardiographic features of right ventricular hypertrophy you might see. What are the complications of COPD? One of the predominant domain complication is recurrent exacerbations caused by upper respiratory tract infections, like in asthma. So again, it's important to prevent upper respiratory tract infections because this complication, recurrent exacerbations, can push a patient with COPD into respiratory failure. Right heart failure due to pulmonary disease, not only COPD, there are other chronic lung diseases that causes right heart failure. This condition is called copulmonale. Can lead to respiratory failure, and it's a type 2 respiratory failure. You know already we categorize respiratory failure into type 1 and type 2. Type 2 respiratory failure, significant thing is that unlike in type 1, there's a CO2 retention. When there's a CO2 retention, PCO2 is high. Why is there CO2 retention? Because this is due to ventilatory failure. Type 1 respiratory failure is due to ventilation perfusion mismatch or pulmonary shunting. But type 2 respiratory failure is a ventilatory failure. It is either because of the severe narrowing of the tubing system, or if there's a respiratory paralysis in the muscles, respiratory muscle paralysis, neuromuscular problems, again, you can get ventilatory failure. So ventilatory failure you get either because of the severe narrowing of the conducting system or neuromuscular pump failure due to a variety of respiratory muscle paralysis or neurological problems. And the result of that is CO2 retention. So with the CO2 retention is there, the PCO2 is high, and that indicates there's a type 2 respiratory failure. Pneumothorax is another complication. The reason is that in COPD, particularly when there's a lot of emphysema, one gets thin-walled air-filled cavities called bullae. These air-filled cavities can rupture into the pleural space, causing pneumothorax. This is a chest X-ray, the right lung and the left lung. If you look at these, compare these two lungs, one can see that left lung looks bigger than the right. Also, if you look at the rib spaces, you can see on the left side, rib spaces are wider. Another significant thing that you see here is, unlike in the right lung, there are no vascular markings. Why aren't there any vascular markings? Because this air is not in the lungs, it is in the pleural space. So where is the lung? In that case, lung is collapsed here to this little thing. Yeah, there's a question. I'll come to the question also in a minute. Once I finish this one, I'll come. So there's a pneumothorax here. The radiologically, how do you recognize this? Trachea may be shifted to the opposite side if there's a tension pneumothorax. But the important thing is there you can see black lung, air here without any lung markings. So what would be the clinical signs that you would expect if you examine this patient? If You examine this patient, the lungs, see, movements will be reduced, breathing movements will be reduced, trachea will be shifted to the opposite side, percussion note will be hyper resonant here. When you listen to the breath sounds or auscultate, breath sounds will be absent or markedly reduced. Vocal frimiters and vocal resonance also will be markedly reduced. So these are therefore the signs, clinical signs of pneumothorax. And the radiological signs are here. You see the uniform lung field without any vascular markings, and you see the collapsed lung here. Right. So going to the other complications, if the patient has been having hypoxemia for a long time, there will be polycythemia. And having polycythemia is also not a very good thing, because it's just like having a lot of traffic on the road. Circulation can become very sluggish. You can have symptoms like headache, giddiness, dizzy feelings, and also thrombosis, cardiac or stroke, particularly cerebral venous thrombosis, all nasty complications of polycythemia. There are many systemic effects of COPD. Now it is widely recognized that COPD is not just an inflammatory condition which is confined to the lungs, but there's an inflammatory spillover or inflammatory markers or the chemical mediators that causes inflammation. There's a spillover into the systemic circulation, and there are many systemic effects that cause a lot of disability in the patient with the COPD. There's gross muscle wasting, there's fatigue, weight loss, depression, and even increased risk of ischemic heart disease, coronary vascular disease are all recognized as systemic effects of COPD. They have osteoporosis in the long term. So it's important to recognize these complications and look for these, and also to realize that these things add to the disability that patient has. So the disability is mainly due to breathlessness because of the pulmonary function problems, but not only because of the lung disease. These things, these systemic effects also add to the disability the patients experience with COPD. Manage